Hi, I'm Dr. Dave Hashemi. I'm the current Mohs and Laser Fellow with Dr. Geronimus in New York. I'm going to be speaking today about combination radiofrequency microneedling used in combination with a 1550 nanometer non-ablative fractional resurfacing in the treatment of acne scarring. I have no relevant disclosures. So in terms of background, so as we all know, there's a range of both lasers and energy-based devices used in the treatment of acne scarring, including both ablative and non-ablative fractional resurfacing, as well as radiofrequency microneedling and picosecond lasers. Most of them work through the stimulation of collagen generation, as well as potentially impacting the stratum corneum depending on the modality. And we often choose the device of choice based on both scar type as well as patient factors such as skin type, as well as severity of acne scarring. Historically, they've been used as standalones, although increasingly people are exploring the benefits of combination approaches, and we're specifically going to be speaking about the benefits of combining radiofrequency microneedling with fractional non-ablative. So our study included 21 patients from January to October, specifically for atrophic acne scarring, and the devices that we used were the Genius as well as the Fraxel Dual, specifically the 1550 component. Importantly, they were used sequentially. So first we would use the radiofrequency microneedling, and then immediately followed by the fractional non-ablative. Our typical patient was 27 years old. We had about even split in skin type between about 52% type 1 and 2 and 48% type 3 and 4. In our study, the patients had a median of 2 treatments, and although I'll say a number of these patients have had additional treatments since the study as well. Our results were overwhelmingly positive. Our average patient had excellent improvement, and importantly, 38% of those patients included patients who had previously received standalone treatment. And all 8 of those patients who had previously received standalone treatment saw significant incremental improvement from the combination approach. We saw no significant adverse effects, which I think is important given that we were combining 2 heat-based modalities. So we had no episodes of prolonged dyspigmentation, erythema, edema, and I would say that the downtime that we saw was typically around the same as the downtime you would expect from just the 1550 alone. So here's just one example of the results we've been seeing. As you can see, significant improvement in particularly in the atrophic component of the patient's scarring. Here is another example, and this is after just 1 treatment in this patient's case. In terms of settings, so again, first we start with the radiofrequency microneedling. We do 2 passes, first at a 2.4 millimeter depth, and then again at a 2.2 millimeter depth, and then immediately followed by the 1550 Fraxel with a depth of 70, coverage of 35% or treatment level 12. And then about 0.5 kilojoules per cheek, although I'll say that as we've seen that patients have been tolerating this well, we have been increasing that total target energy to about 0.6, 0.7. So interestingly, there was actually a recent study published in DermSurge from Dr. Goldman's group in San Diego, showing that when they alternated the radiofrequency microneedling with 1550, they actually did not see significant incremental benefit over just standalone treatment. I think the important distinction in our case is rather than alternating the treatments by visit, we were actually doing both in the same visit, and then saw a significant benefit from that. And so that raises the question of why mechanistically this might be the case. So there was a study, I think it was last year, out of Dr. Chung's group at Beth Israel, looking specifically at the histologic analysis of the depths that radiofrequency microneedling and Fraxel are targeting. The radiofrequency microneedling tends to impact around 100 to 300 microns, whereas the 1550 may be able to go significantly deeper, particularly in with the settings that we were using of 70 millijoules. And so we believe that the benefit is largely due to the heterogeneous nature of acne scarring at different depths. And so by using the two in combination, we may be targeting different depths, and we also may be getting some synergy in terms of heating at multiple different depths. So this is just one final example of some of the benefits that we've been seeing. I would say that even over the course of my fellowship, this has gone from sort of something that we were trialing to see if there was benefit to it, to now it is, I would say, our go-to approach for the treatment of acne scarring. Obviously, there's still significant benefit to, let's say, ablative resurfacing, but in patients who don't want the downtime or don't necessarily have the severity, this has become our go-to treatment for acne scarring.